Today we're going to talk about preoperative medications, chapter 13 in your book. We're finally getting to the part of your book that I find to be really interesting. A lot of the upcoming chapters are going to talk about anesthesia drugs and what we do to help the patient in surgery while they're asleep. And I think you guys are going to find this all really interesting. So the topic of this chapter helps to ensure that the surgical patient is comfortable and safe. And also, it's just important to be able to understand these drugs, their purposes, and how they're administered in order to help the anesthesiologist in the room. We will define some terms and abbreviations related to pre-op medications, state their purposes. We're going to talk about preoperative evaluations, some medications given before surgery, examples of each group of medications. These next couple of slides, we're going to talk about some terminology. So one group of medications we'll talk about in this chapter are sedatives. These have amnestic effects. That means that they will produce memory impairment. And at high doses, these agents produce anterior grade amnesia, which means from a point forward, their memory is impaired after that agent is given. Also, analgesics. These are designed to relieve pain. And basically it's the absence of a normal sense of pain. Anticholinergics, these are another of the major medication categories considered in this chapter. They're an agent that blocks parasympathetic nerve impulses. They are also a vagolytic, which means it blocks the receptors on the vagal nerve, and a parasympatholytic agent. Anticholinergics have anti-sialagogue effects. This means that they reduce oral secretions, specifically in our instances, we're really talking about saliva. Anxiolysis, this is the ability to relieve anxiety in a patient. Aspiration is the inspiration of foreign material into the airway. Benzodiazepines, this is a chemical classification of agents used as sedatives. It's the most common type of sedative also. NPO, this is going to be a common term when you work in the medical field. It's known as nothing by mouth. Opioids are analgesics. They're given preoperatively to help relieve pain. And they can be, as if you remember, natural, semi-synthetic, or synthetic. And they're going to have morphine-like actions. And vagolysis, this is what anticholinergics achieve. They block certain receptors on the vagus nerve. And if you want a little refresher, keep in mind that the vagus nerve, this regulates heart rate, keeps the GI tract in working order, and also helps control several nerves of the throat and voice box. So anytime a patient's going to have surgery, they need to have what's called a preoperative evaluation. So this has to happen before any preoperative medications can be given. The important thing with this, it's going to help to gather any pertinent patient information, and it's going to also help to outline the optimal anesthetic plan. This is going to be given by the anesthesia care provider before anything is given to them. Information is going to be gathered from several sources, including their medical record. They'll look at that. Preoperative patient interview, so actually a one-on-one talking, physical examination, and review of any preoperative testing results. The preoperative evaluation, we said this consists of a patient questionnaire, and so the patient will typically fill this out ahead of time, or maybe if they're not a scheduled surgery, it's more emergent, then these questions might already be in their chart to be reviewed. And then typically the anesthesia care provider will be the one to follow up and do an interview with this patient to ask any questions that they want to maybe get more information on. You can see here, this is figure 13.1. It's going to show the top of a questionnaire. You know, it's pretty common to what you would see at the doctor's office anyway. Name, age, weight, height, date, allergies, current medications they're on, and if they've had any prior procedures with anesthesia. Here's the second part of that figure. It's going to be the bottom of a questionnaire. This just goes more into detail about history of certain body systems, anything that might affect how they process drugs, if they've ever had issues with anesthesia, pregnancy, all of those things are covered here. The second component of the pre-op evaluation is the patient interview with the anesthesia provider. So this is where they'll follow up, and if they want to get any more information about anything that the patient answered on the evaluation, they can. And also it gives a chance for them to answer questions and establish a relationship with that patient. After the pre-anesthesia questionnaire is completed, the anesthesia provider will complete a document like this. It's their evaluation form. So it has a top portion that you can kind of see here, and this is figure 13.2 in your book. So it'll talk about procedures they've had done with anesthesia, if there's been any history of problems, malignant hyperthermia where that body temperature gets too high, difficult airway, which means maybe they're hard to get intubated, put that breathing tube in. Do they have a history of nausea and vomiting after surgery or anything else? They'll note any dentures, partials, if they have any missing or chipped teeth, any loose teeth, and then neck mobility, airway obstructions, all of those things, basically medications. It's just a way for them to gather all their pertinent information into one part of a document. And then what you see here is going to be the bottom portion of the evaluation form. This is devoted to impacted systems, any comments they want to add, and then diagnostic and lab studies as well. Also, they'll put any notes in here and add signatures as needed. So forms aren't going to be the only portion of the preoperative evaluation. A physical examination is going to be a good way for the anesthesia provider to get information. So a big part of this is they want to look at the patient's physical status right before surgery. They want to take note of all their body systems. If they have kidney, liver issues, that's going to be important because that affects how drugs are metabolized. Also really important is going to be an airway assessment. A lot of times doctors are going to have patients to open their mouths. They want to see how wide they can open their mouth, just because when they're intubating, that's important. Also neck mobility, are they able to lean their head back where it's easy for the anesthesiologist to get a view of their throat? Those are going to all be important assessments. Depending on how the preoperative evaluation turns out, sometimes that anesthesiologist wants to get some other tests and order those. If they're not sure about their heart function, how their lungs look, maybe they're worried about their hemoglobin, they can order some different tests. So electrocardiogram, that's going to help to get a good picture of the heart. H&H is hemoglobin and hematocrit study. They're just going to take blood and have that sent out. A chest x-ray will give them a good picture of lungs, and then other tests as needed. Sometimes coagulation studies, if they're worried about the patient bleeding a lot, they can go in and do a PTINR and see if they're clotting appropriately. When all the information has been obtained, the patient's preoperative physical status is classified or given a number. This is based on criteria established by the American Society of Anesthesiologists. In surgery, this is going to go in their chart, and we call this ASA. So a 1 is a normal, healthy patient. 2, a patient with mild systemic disease. The 3 has severe systemic disease. A 4 is somebody that has a systemic disease that's a constant threat to life. And a 5 is a patient who's not expected to survive without the operation. And then you'll see the classification as 6. This is a brain dead patient whose organs are being removed for donor purposes. So that's the only time that would be used. Also, anytime the procedure is declared an emergency, they're going to add an E at the end. So you might have a 2E, a patient that has that mild systemic disease, but the operation is an emergency. Example would be like an appendectomy. They have to have it out. It's an emergency procedure, so if you're waiting too long, it could increase threat to life. So that's where you'd add the E at the end. Preoperative medications are given as needed to prepare the patient for surgery, both physiologically and physically. So we're going to talk about 4 different groups of agents in this chapter. We're going to talk about sedatives, analgesics, anticholinergics, and gastric agents, which are going to include antacids and antiemetics. Sedatives. So this is the first one we're going to talk about. These in most patients will produce a mild drowsiness and can have amnestic effects. So if you remember, we said that means loss of memory. Um, in high doses, the benzodiazepines, which are the most commonly used sedative, remember that, it's going to be important. It'll probably come up on test later. These will produce sedation and anterograde amnesia. So that's where we talked about the patient is going to lose their memory from that point of giving that drug forward. So a lot of times these patients will think that they were anesthetized or put to sleep in a pre-op area. They don't think, they don't even remember coming to the operating room. So you'll get these patients that come in and they'll say, oh, I don't remember ever coming to the operating room. They put me to sleep in the holding area before. No, that's not true. Everybody always goes off to sleep in the operating room, but they were probably given like Versed in the holding area, so they don't remember anything from that point forward. So you'll commonly see Versed or midazolam. This is a very common one that's given before surgery. Also Valium and Ativan. So in low doses, these will relieve anxiety. In high doses, they will provide sedation and anterograde amnesia. Analgesics, the purpose of these is to provide pain relief. They typically have a quick onset too, which is nice. Examples are opioids and morphine, Demerol, all of those. Demerol is a synthetic, and morphine, those will be natural opioids. Typically, these are going to last for about 2 to 4 hours. And sometimes trauma patients or patients who are going to have some invasive monitoring done before surgery, they may be given preoperative analgesics to help with that pain before they actually go and put those lines in. And these will also help reduce the amount of anesthesia needed for the surgical procedure. Keep in mind these do slow respiration, so it's important to monitor the oxygen saturation of these patients. Anticholinergics. So the purpose of these is to block the action of acetylcholine, and it's going to inhibit the parasympathetic nerve impulses. So these nerve impulses are responsible for the involuntary movements of the GI tract, lungs, urinary tract, and more. They're going to control salivation, digestion, urination, and mucus secretion. Examples of these are atropine, glycopyrrolate, and scopolamine. So when we say these block the vagal response, so in certain instances, this is going to be very, very helpful. With these, the vagal response, when you're stimulating the vagus nerve, it can cause the heart to slow down a lot, bradycardia. So, for example, when you're stretching the peritoneum during an exploratory laparotomy, that big midline incision, when you're messing with the bowels, if you're putting traction on the cervix, if you're dissecting the carotid artery, or stretching eye muscles, these can all cause that reflex bradycardia or a vagal response. So these anticholinergics block that, and they help to keep the heart rate up. These are typically given through an IV, and they do have different onsets and durations of action for each type, so it's important to use them appropriately for depending how long you need to block those impulses. Scopolamine, we'll talk about this a little bit down the line too. It has multiple indications, so it does help in this instance, but it also is an antiemetic too that we'll talk about. So anticholinergics, routinely, they're going to be used for intubation because they will help to control that salivation. They can also be used in oral surgery and in bronchoscopies. The final group of pre-op medications we'll talk about are the gastric drugs. These are needed because a lot of times the anxiety and fear that patients have can initiate a stress response that's going to be mediated by the sympathetic nervous system. So what this does is slows or stops the digestive process. Also, you'll see this in trauma patients. So these gastric agents help to minimize the possibility of aspirating and during anesthesia. So if you remember, aspiration is getting, it could be food, liquid, anything like that into the lungs. Antacids, these are going to decrease the acid production or neutralize existing gastric acid. Examples of that are Tums, and typically in the operating room, more specifically, you'll see Bicitra. And then antiemetics, these decrease the potential for nausea and vomiting. Keep in mind that gastric secretions are still present even when a patient is NPO or haven't eaten 8 hours before surgery. So that's why there's still a risk of aspiration, and you want to neutralize those acids basically. And there are a couple things that are going to cause patients to be at an increased risk for aspiration. If somebody has a GI obstruction, bowel obstruction, obviously things are not moving correctly through their system, so it's going to kind of back up, so that puts them at increased risk. If they have a history of GERD, diabetes, obesity, and pregnant patients in labor or scheduled for C-section, those all increase the risk for aspiration. Gastric agents are going to be administered to patients at an increased risk for vomiting and aspiration. Sodium citrate is the most commonly given pre-op oral antacid. This is Bicitra that I talked about on the last slide. It will neutralize acid in case of aspiration, so it's not going to do as much damage basically. Zantac, Pepcid, and Tagamet, these are all common H2 blockers. And an H2 blocker, this blocks gastric acid secretion. The H2 blockers interfere with the production of gastric acid by parietal cells. So these are not used in emergency surgery, these H2 blockers, because it doesn't change the acid already present in the stomach. It just blocks basically that new acid from being formed. Another class of drugs within gastric agents are the proton pump inhibitors. These are prodrugs. So if you remember back, prodrugs are given in an inactive form and then the body changes them into an active form. Basically, they bind with an acid pump of the parietal cells and prevent the release of gastric acid. These are most commonly prescribed for GERD. You're probably familiar with some of these listed here. Prilosec, this takes days to become effective, so it's not going to be something that's given right before surgery. But there's Prevacid, Nexium, Protonix, and Acipex are all in this category. There's also a subclass of gastric agents known as antiemetics and gastrokinetics. Antiemetics like Zofran are given preoperatively to reduce nausea and minimize the possibility of vomiting, and they also reduce post-op nausea and vomiting in at-risk patients. So some people are more likely to get sick after surgery with that nausea and vomiting. Pediatric patients, patients receiving opioids, barbiturates, or etomidate. Females, longer procedures, that's going to make for an increased risk because they're under anesthesia longer, and abdominal procedures. Those all tend to have a more likely risk of post-op nausea and vomiting. So keep that in mind. Zofran, this can last for 12 to 24 hours. And with dexamethasone, it's going to add extra effect, especially for that first 3 hours after surgery to help with that. And then scopolamine, this is a dermal patch that's left for about 72 hours to help with that nausea and vomiting. Gastrokinetics, so Reglan would fall under this category. It stimulates motility of the upper GI tract without stimulating gastric acid secretion. So basically what it's going to do is going to move food along without adding any acid secretion to it. So it's going to help reduce the stomach contents basically. Table 13.2 in your book will show the gastric agents used preoperatively, all of these that we just went over. Okay, so the last part of this chapter is, as always, the advanced practices for the surgical first assistant. So we're going to talk about a little bit about medications from the medical setting to the surgical setting. So it's important that you guys are aware of the bowel prep. These are done for elective gastrointestinal procedures. And so these used to be a two-phase procedure. So there was the mechanical phase where they were given something to drink that would empty the bowel, and then a chemical phase, which would be an antibiotic. Now, this isn't really the common practice. Typically, they'll just go through the mechanical phase and they will not receive the antibiotic at home. They may still receive an antibiotic right before surgery that the anesthesiologist would give, but they won't do that at home. The standard prep is going to include instructions for drinking this at a designated time before the procedure. You might have heard of this. The examples are coli, new lightly, go lightly. All of those will fall under this category. And so you answered this in your homework, but why is a good bowel prep needed? This is important because you don't want to miss anything like tumors, polyps, etc. So especially in colonoscopies, they want a clear view of the tract. Also, anytime they're having surgery on the small bowel, large intestine, they want to make sure to clear all that out, because if you're cutting into the small bowel, large intestine, if there's anything in there, it's just going to seep out into the belly and you'll have gross contamination. So it's really important that they're cleaned out, and you can help keep that procedure as clean as possible. Anticonvulsants, these are drugs that are going to help basically people to not have seizures, so epileptic patients. It's important that they continue on this therapy during surgery, that they don't stop these medications before. And then hypertension medicines. This is going to be a medication that's given to anybody with a blood pressure greater than 140/90. About 25% of the population is being treated for hypertension or should be treated for it. And they will also be told to take their daily medications. Now, I know that we say nothing by mouth before surgery, but this is one that they're probably going to want them to take with a tiny sip of water before surgery. Okay, I hope you guys have a great day.